No, I'm sorry.
And hyperglycemic emergencies. And so, as you know, there are two hyperglycemic emergencies: the DKA, diabetes ketoacidosis, and HHS, hyperglycemic hyperosmolar state. It's important to recognize them and treat them because they can cause a lot of complications, and they cause a great deal of mortality. So the DKA pretty much causes mortality about 5% mainly in elderly individuals or individuals with other life-threatening illnesses. The HHS has a mortality about 10-fold higher than DKA. So it's very important that when you get called for a patient like this in the emergency room, you kind of recognize it and start treating it. So the characteristic of DKA and HHS, I mean, they're overlapping syndromes, right? But mainly the diabetic ketoacidosis is an absolute or near absolute insulin deficiency and results in severe hyperglycemia, ketone body production, and acidosis. Develops fairly quickly in about hours to 1 or 2 days, and most common in type 1, but is seen also in type 2 diabetes. The hyperglycemic hyperosmolar state is a severe relative insulin deficiency. They have profound hyperglycemia and hyperosmolarity. There is no significant ketone production or acidosis, develops more over days to weeks, and typically presents in type 2, but it can show up in people that they don't have a diagnosis of diabetes. Again, as I said, so they are overlapping. So you will find people that have characteristic of both. So typically the diabetes ketoacidosis shows up in younger, type 1. They don't have hyperosmolarity, they have significant volume depletion, they have electrolyte issues and acidosis. The type 2, that are usually the one that present with HHS, and they're older, they have hyperosmolarity, volume depletion, electrolyte disturbances, and no acidosis. So the pathogenesis of, I don't want to go into much detail because I just want to give you a practical lecture, but you need to know that when you have, so let's start on the left side of the slide. So when you have absolute insulin deficiency, you have increased lipolysis. So you have increased free fatty acids to the liver, and you have increased ketogenesis, mainly the beta-hydroxybutyrate. And you cannot measure this in the urine, you can measure in the blood. So you have what we call ketoacidosis, right? Also, in condition of insulin deficiency or relative insulin deficiency, you have an increase in counter-regulatory hormones, mainly catecholamines, growth hormone, cortisol, and glucagon. And so you have a decreased protein synthesis and increased proteolysis, and this gives substrate for gluconeogenesis. So you have hyperglycemia. And from the hyperglycemia, you have glycosuria, so osmotic diuresis, loss of water, dehydration, and impaired renal function. In the HHS, again, you have a relative insulin deficiency, so there is absence of minimal ketogenesis, but you have all the others. So you have increase of the counter-regulatory hormones, the hyperglycemia, the glycosuria, and the dehydration. And since it's slower to develop, you have a great deal of hyperosmolarity and altered mental status. So the pathophysiologies of ketoacidosis is, unchecked gluconeogenesis, and so hyperglycemia, osmotic diuresis and dehydration, unchecked ketogenesis of ketosis, and dissociation of ketone bodies into hydrogen and anions, and so you have what we call the anion gap metabolic acidosis. And so these are the main features of the DKA. The factors that can precipitate the presence of DKA, so you will see these very, very frequently in your ICU or medicine rotation. Most of the time, people come in DKA because they have non-adherence to insulin regimen. They make a mistake. They don't use the insulin properly, or now we see a lot of insulin pump malfunction. So people with insulin pump that for some reason pump gets blocked or gets detached or gets removed, they don't put it on, so they come in DKA. Remember, usually we give to diabetic patient a 6-day management because their insulin requirement goes up or goes down depending on what are they doing. And so in case they don't take enough insulin, they come in DKA, they have an infection. Remember, especially in older patients, always to rule out myocardial infarction or a stroke, pancreatitis, trauma, pregnancy. So always go see, we tell our fellows always to go see a pregnant patient that comes admitted with hyperglycemia, or people that come with newly diagnosed, or they are on some medication like steroid, antipsychotics, and now we see a lot of them with SGLT2 inhibitors, although they're not approved for type 1 yet, but we see a lot of people that come with DKA. So this was a study that was published in Nature of Endocrinology in 2015, and so in the US, most people with DKA have poor adherence to treatment. You see 41 to 59, 60, almost 60%. Followed by new diagnosis of diabetes and less likely infection or other causes. So you will learn how to recognize these people very easily. So they have a history of, again, hours to 1 or 2 days of thirst, polyuria, abdominal pain, nausea, vomiting, and weakness. And on physical exam, we will recognize the fruity breath that comes from the ketones, the hypothermia, the tachycardia. Usually they are volume depleted, so they are tachycardic, they have hypotension or orthostatic blood pressure, they have dry mucous membranes, they have the mild respirations, and they are trying to get rid of these acids. And in the HHS, so remember, there is no ketogenesis, but there is definitely hyperglycemia and dehydration, and presents commonly with renal failure, and there is again insufficient insulin to prevent the hyperglycemia, insufficient insulin to prevent hyperglycemia, but sufficient insulin to prevent the ketogenesis. There is usually no significant acidosis, and there is again a precipitating event. So again, people are not adherent to medication. They have a poor 6-day management. They are dehydrated, especially in summer. They have renal insufficiency. They come with infection. They come with myocardial infarction or stroke. They are on therapy. They worsen their glycemic control. So always, when you see a patient with DKA and HHS, always rule out all these other issues that may be there. And usually patients are older. They have more comorbidities. They have history or may not have history of type 2 diabetes, and develops in weeks to days. So there is a greater severity of dehydration, and so hypotension and shock, hyperglycemia, hypernatremia, hyperosmolarities, and altered mental status changes. It's actually one of the requirements to make a diagnosis of HHS. So when you see a patient and you get called in the ER, just make sure they have a comprehensive metabolic profile. You should check the serum osmolarity, the serum ketones, and the urine ketones. Remember, the beta-hydroxybutyrate is the ketones typical of DKA and is not measured in the urine, it's measured in the serum. So it's good to have its serial measurements. Blood gas, lactate, because you have, especially in DKA, metabolic acidosis, so you want to make sure that there is no other causes for anion gap metabolic acidosis. You get a CBC, you can get a UA, blood culture if you suspect an infection, and AKG, just make sure they don't come in MI, and of course physical exam. So the diagnostic criteria for diabetes, ketoacidosis, and HHS, you'll see here. I don't want you to remember mild, moderate, and severe. I mean, this is probably a little bit too much, but usually the plasma glucose level in patients with DKA is lower. In HHS is higher. We say above 250 and about 600 milligram per deciliter. They have acidosis, so you'll see this in the blood gas. their bicarb level is lower in the severe DKA. They have a bicarb less than 10. They have urine or blood ketone, and the urine blood beta-hydroxybutyrate. But remember, ours doesn't measure our urine acid doesn't measure the beta-hydroxybutyrate. They have a serum osmolarity that's much higher in the HHS. They have anion gap metabolic acidosis in DKA, and they have altered sensorium that's a requirement for HHS, and various degree of alteration in sensorium in DKA. And so this is another table pretty much that summarized the previous data, so you can just look at this one. That's probably simple than the other one, so just forget about it. Mild, moderate, and severe. If you can do that, that's great in your note, but you probably won't have time for that detail in your note. So remember that people that come with hyperglycemic emergency, they have a huge water deficit, so they are extremely volume depleted, about 7 liters in DKA and about 10 liters in HHS. They have sodium deficiency, potassium deficiency. So they may have a false hyperkalemia, or potassium can be normal because potassium is trying to get off the cells to correct for the acidosis, but they are actually potassium deficiency. That's important when you have to start the insulin, because the insulin will push the potassium in the cells, and so you have to make sure you prevent severe hypokalemia. They have chloride deficiency, phosphate, magnesium, and calcium deficiency. And so you have to take into consideration all these other electrolytes. So the management, mostly you have to restore the volume and tissue perfusion. So first thing, you give fluids, then you correct the hyperglycemia, correct the ketogenesis, correct the electrolyte imbalance, and then you identify and treat all the other precipitating causes that you may have found in this patient, unless he said, no, I wasn't taking insulin for the last 2 days. So this table, I think, is very helpful because it goes over the management of, it's a protocol for the management of a hyperglycemic emergency. So it tells you how to treat fluids, insulin, and potassium. So we can go over this. So the first thing you have to do is, usually the ER does it, but you may have people on the floor that develop decay for whatever reason. So you give fluids. You should give normal saline unless the patient is severe. So you should give normal saline unless you are worried about correction of sodium deficiency or hypernatremia or hyponatremia. But most of the time, normal saline is good at 1,000 ml an hour during the first 1 or 2 hours. So if you always evaluate the correct serum sodium, and I'll show you how to do that. If the sodium is high, you can give a half normal saline at 250 or 500 ml an hour, depending on the hydration and depending if people have heart failure. If the sodium is low, you should definitely give normal saline at 250 or 500 ml an hour. Most of the people are young, so you shouldn't be worried about heart condition. And then when the plasma or capillary glucose reaches about, this is 250 to 300, 250 for DKA, 300 for HHS, then you change to D5 half normal saline until the resolution of ketoacidosis. When you have, there are 2 protocols for insulin. Here at UAMS, most of the time we use IV. So you give 0.1 unit per kilo IV bolus. It has not been shown to be better than, the bolus initially has been shown to be superior, so not everybody does it. But you can, if you don't give the bolus, you should start your insulin drip at 0.14 unit per kilo per hour. But anyway, this is a protocol insulin IV infusion. The sub-Q, we don't usually use it here at UMS because it requires sub-Q injections every 2 hours. Sometimes I think the hospitalist team does it on the I've seen one time a surgery team do it on the step down, but I don't recommend it because it requires too much nursing and it's not good. mainly it's a nursing issue. So again, when you have insulin drip, you check the you check the glucose every 1 or 2 hours, and then when he reaches the 250-300 range, you reduce the insulin, the drip, to maintain the glucose, around 200 until resolution of ketoacidosis, because remember, you need insulin to metabolize all these acids. So when the glucose goes down, you don't have to stop the drip, you just slow it down and you're giving half normal saline that has some glucose. And then when the patient is alert, can eat, and the gap is closed, you can start the sub-Q insulin. Always remember to overlap the drip with the sub-Q of at least 2 hours, because the sub-Q insulin will take time to get an effect. And then remember, most important, the potassium. So if the patient at presentation has a potassium less than 3.3, then hold the insulin and give some potassium before you start the drip. If the serum potassium is more than 5, don't give it, but check every 2 hours, because again, when you start giving insulin, it may goes down very quickly. And then if the potassium is less than 5, you can add potassium in the IV fluids to keep the potassium between 4 and 5. So basically, you want to prevent hypokalemia. That's important for arrhythmia, right? So again, this is like a repetition. So during the first 2 hours, always give fluids, and then change the fluids to a slower rate, 250 to 500 ml an hour. Evaluate the correct serum. So remember, for every 100 milligram deciliter of blood sugar elevation, add 1.6 to the sodium value. So always correct the sodium. And then use half normal saline if you are worried about correcting too quickly, or you can use normal saline if the sodium is less than 135. And then when the blood sugar reaches 250 or 200 or 300 in HHS, then you change to D5 half normal. And so again, correct the hypokalemia, start the fluids, and then you start the insulin. And then if you should have in the first hour a drop of blood sugar of 50 to 75 milligram, and if it does not, then you can increase the rate, especially in people that are a little bit more heavy, and continue the insulin infusion until the ion gap closes. Then don't interrupt the drip before you start the sub-Q insulin, otherwise they'll go right back in DKA, and we have seen this several times. So remember what are the problems, that even with low-dose insulin therapy, you may have hypokalemia and hypoglycemia. And so remember to check the insulin the sugar every hour. And so reduce the insulin infusion as the blood glucose approaches target to avoid the hypoglycemia. And remember, there is always a lag between the change in insulin infusion and resulting effects. So unless the patient is severe hypoglycemic, but even if it starts to develop low blood sugar, you can always give more D5. And then, so the potassium is very important. So remember, potassium is dominantly intracellular. They have urinary losses due to glycosuria. The stores are greatly reduced, and so the potassium moves outside of the cells during insulin deficiency, presence of the glucose as a cell buffer hydrogen. And so blood levels prior to treatment are usually high, but this is a falsely high because they may drop right quickly during the therapy. So please do not send the patients on a life-threatening hypokalemia. And then so again, just be anticipatory of what can happen, and remember these numbers, and just put potassium in the fluids if the potassium is the values that I've told you before. And so again, mostly important, if the potassium is 3.3, remember, hold insulin and give potassium before you start the drip, and add potassium replacement in the IV fluids to maintain the levels to 4 and 5. The bicarb has never been proven to be beneficial or deleterious as far as changes in morbidity and mortality in patients between pH of 6.9 and 7.1. There are no studies really to support the use of bicarb when pH is less than 6.9. So there are some complications of giving bicarb that may get a shift of the hemoglobin curve to the left. So they can cause CSF acidosis, hypokalemia, or hypertonicity, and sodium overload. So I would say unless somebody tells you to use it, like kidney nephrologists come and tell you to use it, I would say you don't have to worry about. And the phosphorus also can drop. They can have a sharp drop of phosphorus during insulin treatment. However, the treatment is not required. Some people use K-phos, but just for now, think about the potassium, the sodium, and the glucose. That's the most important thing. So remember, the HHS are more volume depleted, 7 liters with 10 liters in HHS, and so usually these are elder patients. So just consider the heart disease. Make sure you don't blast them with fluids if they have heart failure. And then in HHS, usually there is no significant elevation on admission unless the patient is renal failure. And remember, in HHS, there is also replacement required during the treatment. So why people die in DKK HHS? They may have shock, they may have hypokalemia or severe hypoglycemia. They may have cerebral edema, hypophosphatemia, although this is very rare. They may have acute renal failure. They may have a respiratory distress syndrome, thrombosis, or they may die from the precipitating illness, MI, stroke, sepsis, pancreatitis, pneumonia. So always look for the cause. Don't miss what may be the precipitating event of DKA and HHS. So is considered resolved when the hyperglycemic emergency is resolved when the blood sugar less than 200 and there is bicarb more than 18, the pH more than 7.3 and anion-gap less than 12, the HHS blood sugar less than 300, normal osmolarity, and there is regaining of normal mental status, and that's when you can transition people to the sub-Q and stop the drip. So allows the overlap between the subcutaneous and the discontinuation of intravenous insulin. Patients that have previous diagnosis can be restarted to the home regimen unless they have, unless they don't eat much or unless there is some other causes. Then you may want to be a little bit cautious. But patients that are newly diagnosed with heavily previously received insulin can start at 0.5 to 0.7 unit per kilogram per day. Sometimes a good indication of how much insulin they require can be by the requirement of the insulin drip. So if they require a lot, maybe we give a little bit more insulin at the beginning. But again, at that point, hopefully somebody from our team will be called and so we can help you with that. So remember that to treat the underlying cause of the DKA, remember to watch the potassium, to remember to watch the ketone concentration and don't stop the drip too early. Remember to follow the bicarb, because sometimes people they may have so basically if there is a misinterpretation of expansion acid and ketoacidosis, because if you get a lot of normal cell in your bicarb is going to go down, so just remember that as well. So they may develop a non-anion gap acidosis just from getting too much fluids or interrupting the IV too soon. So sometimes, people are not ready to eat, or the anion gap is not closed, or they want to rush the patients out of the ICU because they need beds, and so that's not good. Some people are not given an adequate dose of insulin, and so that can send the patients right back into DKA. Some people stay in the hospital. We have the opposite problem. Some people are staying in the hospital too long because we want to make sure the insulin is perfect, but that when they go home, things are going to change. So don't get too obsessed with control of blood sugar, especially new diabetes. There is sometimes people that don't receive diabetes education. They are discharged on the weekend. The diabetes educator is not here, so they go home. They don't know how to do his insulin, and they come right back, or they have inadequate follow-up in clinic or primary care. So remember, especially in people that are new for diabetes, remember that patients have to go home and they have to know how to test their glucose, how to test their ketones, how to manage their glucose during sick days, and how to use supplemental illness during illness. They make sure that they go with insulin, because now most people cannot afford that expensive Lantus, so make sure you check with their insurance or with the pharmacist which insulin they can afford. If you send home with pen and they cannot pay for pen because it costs $800, they'll be right back in DKA. So just make sure you address the social factors. That's probably one of the most important things in diabetes that we often forget. So the pre-discharge, if the endocrine team is on board, we should do that, but just in case we don't get called, or you want to be an overachiever on your team, just don't forget to give dietary information, glucose monitor, make sure patients good with strips, medication, needles, make sure they know their treatment goals and when to call, give some contact phone number for our clinic or for the educator. Make sure you send them with the medical alert bracelet, so if they get in the store and they get hypoglycemia or hyperglycemia, people, they know what to look for. And the survival skills training, which they know some rules how to manage their diabetes. Any question? So we can go to the hypoglycemia. So you will get called in your night, during your nights, probably 2 or 3 times a night. So you have to know at least what to do and what to look for. So the hypoglycemia, strictly talking, is a blood sugar less than 70, and most of the time is an effect in the hospital of anti-diabetic therapy, not only insulin, but even oral medication. And remember that severe hypoglycemia is very frequent in type 1, a little bit less frequent in type 2, very insulin resistant, but can happen. So the factors that contribute to hypoglycemia are insufficient patient education, some medication, for example, the sulfonylurea if given to elderly people, or renal failure. And when people have an aggressive treatment targeting normoglycemia in the hospital, then people get MPO for a procedure, and they still have given a medication that can cause hypoglycemia. In the hospital, especially at the VA, there is a poor coordination of insulin and food delivery, or a PRI too, because people get this short-acting insulin and then the food is not there, and so when they arrive to eat their hypoglycemia, actually, they have abrupt changes in nutritional intake, again, for whatever hospital reason. There is a discontinuation of parenteral enteral nutrition. They have worsening of renal failure, liver failure, they are severely sick, so maybe they don't eat, or the disease itself can cause hypoglycemia. They get a steroid taper, so they're very hyperglycemic, they're on prednisone 60, all of a sudden they go to prednisone 10, the insulin doesn't change, and they get low. And importantly, remember that people that have frequent hypoglycemia don't feel hypoglycemic anymore. So they say that you have to feel hypoglycemic again, you have to be hypoglycemic for at least 3 weeks. So people may not even tell to the nurse, I feel hypoglycemia, check my blood sugar. So there are a lot of issues that can happen, a lot of mistakes that can happen in the hospital. And remember that the sliding scale is not a treatment. The sliding scale serves to correct the insulin that is given during meals. So in the hospital, we see every day sliding scale Q4 hours, and so the nurse will give it. People won't eat, and people will become hypoglycemic. So remember to put the sliding scale off all the time in sync with the pre-meal insulin. You know, the other things, so, well, we can move on for now. But for you to know, just don't just put a sliding scale automatically. Just realize what you're doing. Especially at the VA, there is no proper order set for sliding scale. So you have to change it one by one to put it before meals. And most people don't do it, but that causes problems. And so, especially you will get called at night because patient is MPO, was given insulin and is now hypoglycemic. They don't eat. Again, they were on D5 for some reason. Now they got stopped, and so all these issues that we talk about, you'll be called. And remember that people with hypoglycemia, they may have arrhythmia, they may have altered sensorium and vision, fall, they may aspirate. And also, they say that the hypoglycemia is a pro-inflammatory, procoagulant state and can cause endothelial dysfunction, so can cause vascular issue as well. So there is this study has evaluated the effects of daytime versus nighttime hypoglycemia on cardiovascular risk. And so at nighttime, you have more cardiovascular effects. So you have heart rate, transient increase of the heart rate or bradycardia, atelectopic, prolonged QT, or preventricular
premature.
Yeah, sorry. Thank you. So just don't make sure you evaluate the patient that's hypoglycemic. That's the bottom line. And in these studies, they have evaluated the hypoglycemic rates in the intensive IV insulin protocols, and they said that pretty much up to 17% have hypoglycemia below 40. And severe hypoglycemia is more likely to happen with intensive insulin therapy than conventional glycemic control. So this has changed our way of managing hypoglycemia in the hospital. So in the hospital, we are not as strict, and we allow a blood sugar of 140 to 180. So you'll see us, if patients wake up with a blood sugar of 80 or 100, is too low for the hospital. And so we want to avoid that. It's perfectly fine at home, but not in the hospital. And so has been shown that severe hypoglycemia, especially below 40, double the risk of mortality. And so we want to avoid hypoglycemia in the hospital for sure. And so again, this nice sugar was published in the New England Journal of Medicine 2012 and showed that the severe hypoglycemia was associated with a significant increase in mortality. So if you get called for blood sugar less than 70 and patient is on IV insulin, you stop it. And if patients for some reason, but this will happen mostly in the ICU, for example, we can control the blood sugar. They're not in DKA, but sometimes it's impractical to give any other kind of insulin. So this is rare, but imagine you get called on the floor. So if the patient is able to eat and drink, you can give rapid-acting carbohydrate. Every floor has juice, orange juice, or so that raises your blood sugar. People are instructed to keep with themselves in the outpatient sugar tablets. If the patient is MPO, so maybe cannot swallow, you can always give the 50 and maybe start IV D5 in water. If the patient is altered, and then you can give the 50, 1 amp or half amp, and again start the IV, or you can give glucagon, 1 milligram IM, and that will raise the blood sugar as well. So just remember the simple: go see the patient, try to understand why he developed hypoglycemia, see if there are any medication errors that can be resolved. They were giving medication inappropriately, just review the chart and go see it and figure out what's going on. So the other thing that you have to recognize is the hypothyroid coma. So most of the time we get called for hypothyroid coma, but actually it's very rare. And so this is a result of very severe and untreated hypothyroidism, requires an ICU admission at high mortality of 15 to 20%. Usually people that have hypothyroidism and they either don't take medication or they're exposed to low temperature infection, congestive heart failure, again, cerebrovascular event, or drugs like anesthetic, antidepressant, or neuroepileptic drugs. So just try to get some history if you can from the patients, because most patients will have a history of previous thyroid disease. The symptoms peculiar to hypothyroid coma, so they'll be in coma, they will be hypothermic, they will have a generalized edema with a yellow characteristic color of the skin. You'll recognize they'll have macroglossia, bradycardia, they will have reduced cardiac sound, they will be overweight, if they talk, they can report a constipation, but if they're in coma, they shouldn't tell you that, but family can say that. So they have a long history of probably uncontrolled hypothyroidism. They'll have low free T3 and free T4, and the TSH is usually more than 100, unless the patient has a pituitary issue. And in that case, the TSH is not helpful, right? The workup that you should have, you check an ABG, and you check some lab works. They'll be anemic, hyponatremic, hypoglycemic. They'll have increase of the liver enzymes, creatinine, and cholesterol. Check an EKG. Make sure the QT is not prolonged. Make sure they don't have inverted T waves, and they will have a pericardial effusion. Sorry, you had a question? No. So how do you treat these people? If this is a coma, then you should give T4 and T3 IV. So you start with a dose of 250 microgram, and then 100 microgram 24 hours later, and then 50 microgram per day. In association with T3, there's a lot of debate how much T3 to give. I mean, as a rule of thumb, is 10 microgram every 12 hours until the maintenance T4 is given. Normally, now patients, we rarely give T3, almost never give T3 replacement, because the T4 is converted peripherally, right? Remember, always give hydrocortisone, because you don't know if these people have adrenal insufficiency. So if you give it to an adrenal insufficient patient T4 IV, you really kill him. So don't forget the hydrocortisone. You don't know if they need it or not, but you give it, and then we'll figure out later if we continue it or not. You give fluids, and then you check if they need assisted ventilation, if they need Lasix because they are in pulmonary edema. You treat the hypothermia. And so this is the emergent thing, right? Then when they resolve the coma, we can work out the causes. If they have other pituitary issues, if they have panhypopituitarism. But, the most important thing is the steroid and the fluids and the thyroid hormones. On the opposite side, you have the thyroid storm. And again, you'll be called in the ER for somebody that has fever, that has altered mental status. So is anxious, is confused, he has delirium, is tachycardic, is tachypneic, he may have congestive heart failure, he's sweating, he's hyperemic, he has tremors, diarrhea, nausea, vomiting, and has a history of thyroid disease. And so these, in addition with typical signs and symptoms and a little bit of investigation of the precipitating factors, will make you have a diagnosis fairly quickly. They'll have extremely elevated free T4 and T3 with undetectable TSH, and they'll have increase of the liver enzymes, hyperglycemia, hypercalcemia. And what are the factors that can trigger a thyroid storm? So usually it's a hyperthyroid patient, most of the time uncontrolled, that they either stop their medication or they have surgery for which they weren't prepared very well, like thyroidectomy, or they have iodine compounds. And so, for example, iodine 131 in people with Graves' disease, or autonomy function nodules that they were not prepared. They have a trauma, they have infection, they have pregnancy, they have a DKA. So you may have somebody in DKA and a thyroid storm. The other causes are pretty rare, but now we see some with the use of tyrosine kinase inhibitors that are used in oncology quite a bit. So remember to look for precipitating causes as well. And this is a score that has been pretty much validated in 1993 and helps you diagnose the thyroid storm with a, so if the total score is more than 45 is likely, less than 25 is unlikely, 25 to 44 it may be. So again, you'll see that people have fever, they can reach up to 104, that gives you 30 points. They'll have altered mental status, they'll have tachycardia or atrial fibrillation, they can have CHF, they have GI, nausea, vomiting, abdominal pain, jaundice, and they present a precipitating history, the one I was talking to before. Like, for example, the patient that had surgery 1 day ago or had radioactive iodine and shows up with fever, altered mental status, tachycardia, congestive heart failure, then you have to think of thyroid storm. Fortunately, we don't see that often, but we have seen some when I was a fellow especially. And so the treatment, first thing you do, you give beta blocker. Again, people may be altered, so they may not take PO, so you give it IV, propanolol or esmolol. Then you give medication to block the thyroid synthesis, right? PTU is better, propylthiouracil is better, because it prevents the conversion from T4 to T3, and or if you don't have it, you can give methimazole. It's a very high dose, 15 to 20 milligram Q6. I mean, these doses are never used as outpatient. And then, again, you give steroids for the same reason. And so these are the first three things. Then the second line therapy, I mean, we do it all the time, but you can give Lugol or potassium iodide or lithium. So basically, this block the secretion of the hormones that are stored in the gland. But you always have to give at least an hour after you have given PTU or methimazole, because if you give iodine, you give substrate for hormone solution, so you may get it worse. So you first block their synthesis, and then you give iodine to block their secretion. And then you think about support therapy. So again, the electrolytes, the treatment of fever, phenobarbital, Lasix if they have heart failure. Some people require mechanical ventilation or cooling mattresses, or in case of hyperthermia. So these are all the supporting measurements that you give in the ICU. So again, it's important to recognize that, because again, the mortality is extremely high, and don't hesitate to call endocrinology, but again, we are home, so you are the one who make the diagnosis pretty much. The last thing that you for sure see is adrenal crisis. So you will see a lot of adrenal insufficiency on your residency. You'll see primary adrenal insufficiency. You'll see autoimmune. I mean, it's the most common, but you may see in infectious disease team people with AIDS that have systemic fungal infection. You may see metastatic disease, bilateral adrenal hemorrhage in people that are anticoagulants, or bilateral adrenalectomy for cancer. You will see a lot of secondary adrenal insufficiency from pituitary disease or from exogenous, long-term exogenous use of steroids, right? So again, this is a high mortality condition, and you should be able to recognize. So the people with chronic adrenal insufficiency, they have fatigue, their loss of appetite, weight loss, muscle pain, they're dizzy, they have nausea, vomiting, diarrhea, they crave for salt, they have orthostatic hypotension. If the adrenal insufficiency is primary, they have elevated ACTH, right? So they are hyperpigmented because the ACTH is produced with the melanocortin. So you will have a lot of MSH that stimulates the melanocytes. You will have hyponatremia, hyperkalemia, hypoglycemia, hypercalcemia, and anemia. The adrenal crisis, these things are 10 times worse. So people present with severe abdominal pain, nausea, vomiting, they're altered, they have hypotension, fever, they have hyponatremia, hyperkalemia mainly in primary because I don't have the aldosterone effect as well, severe hypoglycemia and hypercalcemia. So again, these patients will have either a history of steroid hormone replacement, or they were on steroids for a long time for other reason and they stop it. So again, you will be called in the emergency room. And again, they may have precipitating factors like a GI illness that prevent them to take their pills, or infections, or surgical, they were not given enough stress dose, or physical stress or pain, or they were not taking medications for a long time. And these are 3 studies that I have evaluated. Again, don't forget the pregnancy as well, because steroids requirement increase, especially in the 3rd trimester. And so, again, you'll have to recognize them, and you'll have to treat it, because you want to have time to wait for us. And remember to if you can, take some history. That's always helpful. So their exogenous steroid use, that if they have started levothyroxine, for example, and they were not sufficiently replaced, that the levothyroxine increased the cortisol metabolism, or they were using all these other drugs that increase the cortisol metabolism, like rifampin, or drugs for epilepsy, or people may have ketoconazole or fluconazole for fungal infection, and so they reduce the production of cortisol, so they develop adrenal insufficiency, and again, all these other issues that we talk about. So remember that people with adrenal crisis, they need fluids. So normal saline is your friend in a lot of pain condition, and they need steroid replacement. So if you don't know what to do and you just want to give a steroid dose, you give 100 milligrams of hydrocortisone Q8 hours. And so this will buy you time, and will give you the opportunity to ask for help, so it's never wrong. And remember that the mineralocorticoid replacement is not necessary, because high dose of hydrocortisone has mineralocorticoid activity. So forget about the mineralocorticoid part in primary adrenal insufficiency, just give the hydrocortisone until you call endocrinology for help. So this is my cell phone, this is my email. If you have any question, I left him the lecture, your chief president, the lecture. So if you guys have any question, just let me know. Do you have any question?
In terms of the hypothyroid coma,
yes.
Is it the same as myxedema coma?
Yes.
Is there myxedema without coma?
Yes. So actually the coma is very rare. So the patient that comes unconscious, most of the time, you have seen us, we don't almost ever give treatment IV, right? Most of the time we can take it with PO, because people have stopped their medication maybe a month before, because they couldn't afford, they couldn't get refills, but most of the time we can do it with a slow replacement. Unless, so we use the IV as a last resource with patients is in a coma, requires intubation, and everything is depending on the hypothyroidism, but it's actually very rare.
Because I had a patient with like very characteristic bradycardia,
hypothermia, hyponatremia,
yes, everything, but he was wide awake.
Exactly. So in that case, you may get away. It's not a coma.
It's not a coma.
So you may get away with oral medication, and that's most of the times we have done that. Maybe you will still admit to the ICU for a couple of days.
Would you give him a high dose at the beginning? Like he missed his doses for 10 months, and his TSH was 50.
No, I would not, because they will. Okay, they have some issues with absorption, so you are fine, but you don't want to replace it too quickly again. So it'll take some time. I mean, people expect that people will be right awake. No, their myxedema will take months to resolve. So you have time to start the oral medication at a lower rate. Maybe you start with 50, then after a couple of days you go to 75, and then to 100. But you have time because patient is awake. He doesn't have significant consequences from that. So the IV treatment is really reserved for the coma.
Thank you.
Oh, you're welcome. Anybody else? All right. Well, you guys let me know if you need anything. There's some references. I mean, you have. I mean, I made it probably a little bit more dramatic than it was. You always have upper level. You always have us on call, but you have to try to recognize this, especially if you go hospitalist. You know, you'll see a lot of this, especially now that people will not afford healthcare.